Hello everyone and welcome to the Henry Schein webinar series on YouTube. I'm Dr. Gary Severance. Today we get to welcome Dr. Ann Brady, a private practitioner but also the CEO of the Pankey Institute. Today Dr. Brady will share some of the experiences of being back into practice and the reaction of her team members and her patients. And she'll also show you step-by-step utilization of a product that's been around for about 20 years, but probably not many know about, the Optradam. Dr. Brady, thanks for joining us.
Thanks, Gary. Honored and excited to be here with everyone. I think that I'm in the same place right now as most of us in dentistry. I actually practice in Arizona, and we were able to go back to practice last Friday. I didn't do it the first day, but we have been back in the office since Monday, seeing patients, trying to get our feet underneath us and get comfortable with the whole new version of dental practice right now and how that's going to go. I've actually had several conversations either on podcasts or webinars and with friends that it actually feels like this piece has been much more stressful than the piece where we shut down. Shutting down was easy and just dealing with the uncertainty. Opening back up has been far more of a challenge. And what I want to talk about today is just the things that I've been doing here in my office, the things that I'm thinking about, address maybe some of the questions I've been getting from lots and lots of people around the country emailing me and saying, are you using this? Are you using that? How are you going to do this? And so I think, like most of us, part of the confusion is we're getting so much information and it's coming at us from so many directions. I will tell you that I've made a decision personally that I'm going to get my information, or I'm going to use information that I know is coming from a well-vetted, reputable source. And instead of going and saying, what's the latest thing that somebody's posted on Facebook or the latest thing I can find on my Instagram feed that I absolutely have to buy this, I'm actually relying on going to the ADA's website. So, as a member of the Arizona Dental Association, I've actually loved the fact that they're emailing me every single day with updates and information. I actually just answered a survey where they asked, have you ever read these emails before? And I said, no. And they said, are you reading them every day now? And I said, yes. And I think that might be true for all of us. Or go to the CDC or OSHA's website, or, go to some reliable sources. And one of those that I will tell you that's been really phenomenal has been going to the dental manufacturers and dental distributors and asking them for information and, what are they recommending, and what different things have some science behind them and what things don't. And we're just going to use it because it feels intuitive. But as a basic premise, I'll just share with you kind of what I've been doing in my practice in Arizona. And what the first thing we did was we instituted a series of pieces of what I call our pre-screening protocol. So I actually took the questionnaire that was sent out by the American Dental Association. I looked at it in combination with some things that were recommended by the CDC. And I created kind of my own version of that form. I didn't want to change the questions too much because I don't want to change it in the way that it's not accurate. But I wanted it to make it a little bit more friendly. And so we turned it into the name of my practice is Desert Sun Smiles, a Desert Sun Smiles form instead of an ADA or a CDC form. And Donna, who works in my office and does scheduling, is getting that form to everybody prior to their appointment. So minimum 48 hours ahead. I actually have a lot of older patients in my practice and they don't have email or a way to fill it out and scan it and send it back. So she'll do it with them verbally. She'll ask them all of the questions. And so what are we trying to do? We're trying to screen out people who have a high risk of having been exposed to COVID-19. So, we're asking them, have you been out of the country in the last 30 days? Have you been out of the state of Arizona in the last 14? And if they say yes, where? And if it's one of the hot spots, we're asking them to just delay their appointment, and then asking them about signs and symptoms of any respiratory disease. And we're just going through that questionnaire. We're doing it 48 hours ahead, but then we're also doing it right before their appointment so that if anything changed in the last 48 hours, we've got that information. As part of our pre-screening protocol, once people get in the office, we're going to do a couple more things. But let's also talk about the transition to getting to the office. I know I've heard lots of different things. People are asking patients to stay in their automobiles, text or call when they arrive in the parking lot, and then the office calls them when they're actually ready to take them back so they don't ever have to sit in a reception area or a waiting room. We thought about that, but I will tell you, it literally is going to be 107 degrees in Phoenix, Arizona today. And staying in your car, even with the air conditioning blasting, can be kind of uncomfortable here. So what I did with our office is two things. Number one, we jockeyed our schedule. And I think for most of us, we like start appointments on the hour. And if you have multiple hygienists, everybody starts on the hour. And that's not what our schedule looks like now. So when both my hygienists have been here this week, one every appointment is on the hour, and the other was at 15 minutes after the hour. So their schedules were jockeyed, and then we jockeyed my schedule as well. We've also reduced volume, and I know that that presents a production challenge, but temporarily we've reduced the volume of patients coming into the office until we figure out how to manage this. And then the other thing I did is I came into my office last weekend, and I got rid of 2/3 of the chairs in my reception area. And so I only have 3 seats out there, and they're easily 6 feet apart if they're not more than 10 feet apart. So that we can let people come into the office, and we are asking that they wear a mask into the office. And on the off chance, and we haven't actually had it happen yet this week, that we have 2 people out there simultaneously, they can get pretty far apart from one another. And then, of course, asking folks not to have any family members come. And, our practice has always been a family practice, and most of the people in that family are our patients. And it's really common for them to come together, and then they just hang out and they talk and they're here together. And we're asking them not to do that. And again, in my practice, in some ways, it's been a smidge easier just because I don't have a lot of pediatric patients. Most of my patients can drive themselves, but we have had a couple of those, and we've literally just asked that they drop the person off, but that they either stay in their car or they can, turn around and go home, and we'll call them when the appointment is over. But just try to think through the logistics. And I will tell you, this week's been great because we've worked through it. No matter how much I thought through it ahead of time, actually living it this week has helped us work out some of the bugs. And I've been super glad that we had a lower volume and a slower pace so we could think on our feet. Once folks are in the office, we review those pre-screening questions with them again, and then we are taking temperatures. I actually did order a couple of non-touch infrared thermometers way back at the very beginning of this. It took about a month to get them, but I had them before we reopened. And we're doing screening with those forehead thermometers. And I've actually had one patient this week where we actually had to send them home because they were above the 100.4 is the standard the ADA sent out to everybody. And we had to send them home. So we're doing that. So we were glad that we're doing those things. And, then thinking about like, how are we protecting ourselves? I think this is the place where we've gotten the most questions. I've seen the most consternation, I think is the right word, amongst dentists and hygienists and team members, is how do we protect ourselves? And, one of the things for me that I just believe about dentistry. We've always been good at this. We have always been at the top of our game in protecting our team members and protecting our patients. When I think about even before all this started, the meticulous nature in which we have managed personal protective equipment and infection control. And I mean, I've been practicing dentistry for 32 years, and I can go back to what we were doing when I first was in dental school and started. And I can see how that shifted in the late 1980s and 1990s. And we kept doing it even after some of the initial things we were concerned about back then went away. We've held those standards. And what's been great for me is seeing patients this week. That's what I'm hearing from my patients. I actually have had way fewer people be anxious about coming to their dental visit than I expected when we started to call them. And what we're hearing from our patients is You all have always been good at this. We trust that, you're getting the right information and that you're taking care of us. And so that felt really good and reinforces to me that this is something our profession has focused on and we've really made a priority. But our personal protective equipment is different in the office this week than it was last week. We are wearing different masks, and so I was able to get a small supply of N95s. But more than that, I got the KN95s, which are similar masks, just international standards. And we're wearing those and getting used to wearing those and the feel of having them on our face. I have to tell you, I was kind of concerned about what it would be like to breathe through one. It's actually way more comfortable and way easier than I thought it would be from what you were hearing on the news or hearing people talk about. And we're doing that. And we're actually putting an ASTM3 mask over the top of it so that the KN95s and N95s don't get contaminated. That might be overkill, but that's what we're doing this week. We're wearing face shields. And again, I was able to get a couple different styles of face shields in small quantity in the office. And that was good because it's turned out that they're not all the same. And I have one team member that likes this style and a different team member that likes another style. Part of it is, do you wear loops? Do you not wear loops? How big are your loops? Are they through the lens or do they flip down because they have a different profile? So having some variety of that has been really good. Um, we're everybody in the office has always worn scrubs. We're wearing street clothes in and then changing back. And now we're doing, either disposable gowns or laboratory coats so that we're covering everything. I will tell you the most tricky piece of the PPE wasn't donning it and getting it and it was interesting to get it in the office, but we got it. The most interesting thing we had to figure out this week was the process of putting it on and taking it off and which spaces in the office we do that so we're not contaminating spaces and just the sequence of how you take stuff off and wash your hands and move around the office took us probably a day or two of sort of tripping over ourselves and figuring that out. But we've been in this, today will be our fourth day, and it actually feels almost routine today. By the end of the day yesterday, I felt like, okay, we have a system, everybody knows what they're doing. And then we've got patients, actually in the chair, and something that we actually didn't do routinely before this, that now I think will be part of what we do moving forward, is a pre-procedural rinse. And, as I've gone in and I've looked at all of the science and the research, and there's not a ton in dentistry. We have some limited science and research about aerosol spray. We don't necessarily have data about what's in that aerosol and and like things like viral counts and bacterial counts. I'm sure that'll be coming really rapidly around the corner any day now. But pretty much all of those articles, when you look at all of the science, you go to the folks who've studied infection control, the idea of a pre-procedural rinse is in all of them as a way to reduce your risk. And of course, at the time, we were thinking about exposure to the bacteria in the biofilm and the sulcus, and now we have other concerns. But we had started doing a rinse even in the couple of days we saw patients before we shut down, and then we picked it back up Monday morning. Right now, we're using hydrogen peroxide, and we're just using straight hydrogen peroxide that we were able to buy through our dental supplier. People have had conversations and asked me about chlorhexidine. This is not my area of expertise, but I will tell you everything I read is that hydrogen peroxide is the chemistry to be using right now, that we're not sure how chlorhexidine interacts with the virus and whether it would actually protect you, but we know hydrogen peroxide does. And other people are asking me, can you use hydrogen peroxide based mouthwashes? The answer is yes, if you're looking at the percentage. So you just have to get above the threshold of percentage of hydrogen peroxide. Yes, it tastes awful. I hear that every single patient. Oh my God, that's awful. But they're all doing it, and my experience so far is our patients are appreciating the extra measures we've gone to, the new procedures, instead of being fearful of it, which people were worried about. They've been really appreciative of it, and they're telling us that. We've even gotten a couple Google reviews saying thank you for taking all those extra steps. So they're thanking us for making them rinse with something that tastes bad. I've also heard in different web programs that I've been watching and on different places that you can actually also rinse with a mixture of essential oils. Again, for me, I want to kind of keep my feet where I know there's some scientific data to back up what we're doing. And that's just not an area that I know enough about or that I'm comfortable in. But certainly, if that is more appealing to you, you just need to do the legwork to figure out what you should be using. But we know for sure hydrogen peroxide meets the bill right now. So we're doing that. And then we get to the conversation really about controlling aerosol. And I know that's been probably one of the biggest conversations people have been bantering about. So if I think about this in layers and tiers, the first layer is let's eliminate seeing patients who've potentially been exposed. That's all that pre-screening. Let's eliminate seeing patients who potentially are actively engaged with the virus and don't know it. That's why we take people's temperatures. And then we have the idea of there's still going to be a certain percentage of people that may have the virus, and we want to protect ourselves and them. And that's PPE, which protects us and also does protect them, by the way, if one of us has it. And I didn't mention, but we are also screening ourselves every single morning and going through that same protocol of answering the questions and taking temperatures on team members. And then it also is about controlling aerosols. And so lots of conversations today about doing that. And there's lots of devices out there. And again, one of the things to think about is we have devices on the market that we think intuitively will help us control aerosols. And the big conversation today has been about high volume evacuation versus non-high volume. So the difference between using an HVE versus a saliva ejector, and something that has a large enough diameter to the bore and actually pulls enough airflow through. But there's an intuitive piece to it. Does it feel like it's going to protect us versus where do we know stuff is going to work? And in my practice for years and years and years, we've used different forms of isolation, and one of those has been to use a rubber dam. And I know as soon as I say the word rubber dam, dentists cringe, and all of a sudden you have visions of being back in dental school and having to put that device on, or maybe the assistants that are listening are cringing because often in a dental practice it's the assistant who places the dam and not the dentist. And I also know that it's not something I think that's been necessarily routinely used day in and day out for restorative dentistry. And there have always been phenomenally good reasons to do your dentistry under a rubber dam. A well-inverted rubber dam not only controls and isolates you from the salivary contents, and so you don't have to worry about contamination from the patient's saliva and getting that on a tooth while we're trying to do today what we all do, adhesive dentistry. But it also controls sulcular fluid. It prevents hemorrhage leakage from the gingival tissues. It actually prevents a lot of the gingival trauma we do because a well-inverted rubber dam is actually retracting the tissues and actually holding the papilla down. So you're going to get less tissue trauma, which inherently means you're going to have less challenges of isolation from damaged tissue that could be potentially bleeding. And you're not then thinking about having to do other control measures like, do I place cord to put this class 2 composite in? Do I have to use some sort of a hemostatic agent? So, there's always been really good motivation from a standpoint of adhesive dentistry for working under a well-inverted rubber dam. The challenge is the thought of putting on a rubber dam often outweighs that, and we try to find other ways around it. One of the things, pre the virus, that was the most common question I ever get when I lecture about adhesive dentistry, about placing composites, about putting in indirect ceramics where we're using adhesives, is how do I get my dentistry to last longer? How do I increase the longevity? It's frustrating when you have a patient in a hygiene chair and you're looking at a restoration you placed and you're starting to see that brown line build up around the marginal interface, because that brown line is a precursor to actually being able to get an explorer and catch that margin, ultimately probably seeing recurrent decay on a radiograph or on a clinical exam, and having to replace that restoration. And I think every dentist that I know, and I think every team member, because we see this too when we do hygiene visits, um, wants the dentistry we do to last longer. And for years and years, what I've told people is, if you said to me, "I'll do anything to get my restorative dentistry to last longer," I would tell you, work routinely under a well-inverted rubber dam. Right? Because adhesive dentistry is technique sensitive. It's so much more technique sensitive than in the days when we used to do a lot of amalgam, which is how I grew up and what I learned in dental school. And moisture and isolation is a key piece of that technique sensitivity. Today, I think we have a whole new set of reasons and a whole new set of motivations to look at working under a well-inverted rubber dam. And that is that we get to put an isolation device into the patient's mouth that separates the environment in their oral cavity and the environment that's existing in their nasopharynx from the dental operatory and from the dental team. So, PPE is just barriers. And a rubber dam is a barrier, and it's a barrier that separates us from the patient's internal environment, so that then on top of it, yes, we can use high volume and we control the moisture and the aerosol from our handpiece or, our air water syringe tip. But a well inverted rubber dam is going to mean that water spray, that aerosol is mostly water, and it's not actually going to have the amount of virus that's present because we're not introducing the patient's saliva or other, mucus. The other part of it is I often have patients cough when I'm doing a procedure, right? We're alternately drowning them and drying out the back of their throat, and it often causes that little tickle and they have to cough. And, coughing behind a rubber dam today is preferable from them not having that device in. Well, years and years ago, I actually became familiar with what I call the kinder, gentler rubber dam. And it's a device from Ivoclar Vivadent, and it's called an Optradam. And if you've not ever seen or worked with an Optradam, there's a ton of good reasons to give it a look before this and now, of course, in the face of what we're dealing with. And again, kinder, gentler rubber dam. So let's talk about why I use the Optradam versus using a traditional rubber dam. Part of it is efficiency and inventory control. Part of it is ease of placement. And part of it is actually patient experience. So let's talk about it from an inventory and efficiency perspective. So an Optradam is an all-inclusive device. You open it up, they're individually wrapped, so we know that what's in there is sealed and hasn't been exposed to the environment until we open the Optradam, unlike traditional rubber dam where you got it in a box and all the dam material is in one box. And the frame is built in. So I also don't have to worry about buying frames and sterilizing those frames. And are they going through the autoclave? And do I have enough of those? So we have that piece of the puzzle that makes life a little bit easier. Then when we think about ease of use, I have to tell you that probably for me, one of the biggest downsides to working with a rubber dam is the clamp. And the reason that's a big downside is, having been a patient and had a rubber dam in my mouth so many times, I understand how uncomfortable the clamp is. But the other thing is, I also know it changes how I give anesthesia. And so if I have to put a clamp on a maxillary tooth, I need to figure out how I'm going to numb the palatal or the gingival tissues on the palatal side. And I would rather do almost anything in dentistry than give people an injection on the roof of their mouth. That's like the worst practice building injection that we do. And if I'm working on the mandibular, I have to give a long buccal because I have to ensure that I've anesthetized the tissues on the labial or the buccal side of those teeth before I place a clamp. And even with the anesthesia in place and the clamp not being a problem during the procedure, the clamp is really irritating to the tissue. Often we actually have pierced the tissue accidentally. And then when the anesthesia wears off, the patient's more apt to have post-op discomfort when we're actually using a clamp. So one of my all-time favorite things about the Optradam is I never need to use a clamp. And I say never, that's 100% word, but let's say 99.5% of the time I can use an Optradam and I don't need to use a clamp. And the reason being is that the actual rubber dam material isn't under the same amount of tension as when we use a flat piece of rubber dam and we're trying to shape it into the back of the mouth. And so, because there's not that amount of tension trying to pull the rubber dam material forward or out of the oral environment, we don't need the clamp in the back to prevent that from happening and to keep the rubber dam material from popping off of the teeth. So the absence, now I don't need to buy clamps and sterilize clamps, and I don't need the clamp forceps and to make sure those are sterilized. So again, easier, more efficient inventory control. But the fact that I don't have to put a clamp in a patient's mouth and I don't have to give them that additional anesthesia already is such a vast improvement over a traditional rubber dam that it just makes me take a deep breath and feel a little bit more comfortable about doing this. The Optradam comes pre-marked for punching your holes, so you never have to worry about punching them off angle and putting it in a funky direction. Pretty simple. You are still going to need to have a hole punch, so you have to pick that up and punch the holes. And then we're just going to place the Optradam and floss through the teeth. So I will tell you, I know lots and lots of you have probably over the years used Optragate, which is a different device from Ivoclar Vivadent that just holds the lips out of the way, that I used routinely for years and years for anterior dentistry because it makes it so much easier. Imagine you had an Optragate that instead of having a hole in the center actually had rubber dam material there. That's an Optradam. And so if you think about putting this in, I will tell you there's one piece of this that you have to learn. And it's the only place that an Optradam is a little bit technique sensitive. But once you learn it, you'll be able to do it over and over and over again. An assistant can do it and place it. And so I'm just going to encourage that you don't think you can intuitively figure out how to place one. Because I promise you, the first time I got them, I thought, I can figure this out. I'm going to put it in like I put my Optragate in. And I actually didn't. And so the directions are really simple. There's pictures that come in the instructions to show you how to do this piece. Or since we all live on the internet, just go watch. There's probably 4 or 5 really great videos of how to insert an Optradam. But basically, it's 2 little plastic frames that are inside the dam material. And there's one frame that's going to be further into the oral cavity. And then there's the frame that's going to sit outside the lips. And the trick is just to reach into the Optradam on what we would call the part that's going to be toward the nose and the part that's going to be toward the chin of the inner frame. And you're just going to grab that and you're going to pull it to the front into your hand. And it turns that back frame into basically the shape of the back of the mouth. And now you're going to insert it. And like an Optragate, now you're going to get it inside the lips on the left and the right. And then once you've got it there, super simple. You're just going to lift the upper lip and push the top part of the frame back under their lip. Same thing on the bottom. I know I'm trying to describe something using words, verbiage. That's way better. As soon as you see a picture of this, you're going to go, oh, I totally get this. This is absolutely obvious. But you do need to see that picture. And then you're going to practice this once or twice, and it'll be easy. So, in my practice, we've been using Optradam routinely for a long time. But if you've not been, right now, as you start to think about putting your new systems in place, how are you going to increase what you've been doing to protect yourselves, your team, and your patients? This is a must-have in your dental practice. And they're super easy to get used to. Our system in the practice is I go in, I give anesthesia. Once anesthesia is on board, and of course that today is happening after they rinse with hydrogen peroxide, but once they're adequately numb, we've got the holes punched in the Optradam, and just like when you've done a traditional rubber dam, punch a few more holes than you might think you need. Go a couple teeth behind where you're working and a couple teeth in front of where you're working. I actually take glycerin and I put glycerin on the, well, I'm going to call it the backside, the part of the Optradam that's going to face the back of the mouth. Because I learned to use a rubber dam lubricant. They don't really make those anymore. So I just use good old fashioned glycerin that we get from our dental distributor. And on a cotton tip applicator, we put it on the back of the Optradam. It just lubricates it a little bit so it slides in between the teeth a little bit easier. Not required. That's just a Lee thing that we do in our office. And now we've already got the holes punched. Once the Optradam's in place, one of the things you'll see compared to a traditional rubber dam is it's super easy now to floss it between the teeth because it's already in place, the frame is already in place, and you're not trying to wrangle the rubber dam material. All you have to do is pop the holes over a couple of teeth and then start flossing. I usually start by flossing from the anterior to the posterior. You can go the other way. If I do have a place where I feel like I have a loose contact on the most posterior tooth, or there seems to be more tension on the dam material than I'm used to, I actually will floss through that contact at the very back hole on the posterior side, and then leave the piece of floss, pull part of it through, make a loop, floss it through, and then I just leave the floss in that gingival embrasure to sort of help retain the rubber dam material back there. I will tell you in a lot of the instructions for this, you'll see people put a slit in it so that people can breathe. If they mouth breathe, they can breathe through that little air hole, or you could insert a saliva ejector through it. I've actually never done that. And today I probably definitely wouldn't do that. If you want to put a saliva ejector behind it so that the patient's not struggling with their own saliva, just loop the saliva ejector and just put it behind the Optradam, and the Optradam will kind of hold it between there and the cheek. And do make sure it's inverted. And you may not remember that it's easier to invert a rubber dam if you really thoroughly dry the teeth. So once you get all of the contacts flossed through and the dam is in place, take an air water syringe tip and dry the teeth really thoroughly, and then floss it again and actually take the floss subgingival as if you were flossing to clean away biofilm, and the dam will invert. And it's that inversion that's going to control sulcular fluid. It's going to basically retract the papilla, retract the tissue, give you really great access. You're going to be super excited when you see the kind of access you have to do a class 2 that's deep. And the gingival box is going to really go down below the tissue. Now you'll be able to get there, see it, and not worry about with your handpiece even cutting that tissue. Then we're going to work with that Optradam in. People ask me often, can you do crown and bridge with an Optradam in? And the answer is yes, absolutely. If you're doing, equigingival margins or supragingival margins, it's super simple to do all of your crown and bridge preps with the Optradam in. So inlays for sure, onlays, crowns, full crowns that have equigingival or slightly supragingival margins. You can do all of your prepping with the Optradam on, and then you can remove it to do the impression. If you're going to go subgingival, you're doing multiple teeth in a quadrant, you can also put the Optradam on. And often what I will do is I'll start and I'll do all of my initial preparation, leaving all of my margins supragingival. And then when I need to drop the margins, I actually will leave the dam in place, but I just cut the interproximal material in between the teeth that I'm doing the crown preps on. And we call that a split dam or slit dam technique. I can now finish my preparations and I've still got the Optradam in place. And sometimes what I will do with that, especially if I'm going to do a slit dam technique where I've slit the dam, we flip the edge over, dry the gingival tissue, and then I actually take bite registration paste and I seal that interface against the gingival tissue. So now the dam is still sealed, saliva can't come up underneath it, but I've got a quadrant exposed, and an entire quadrant is outside the dam material so that we can do our crown and bridge procedures. So there's lots of things you can play with when you start to use a device like the Optradam. You're going to get really good at being inventive about different ways to incorporate it into your restorative dentistry. While you've got it in, you do need to use HVE. And so we talked about this a little bit at the beginning, that high volume evacuation, we've got good science, we've got good data that using an HVE and something with a bore that's greater than 8 millimeters and moves a certain amount of air past it really can reduce the aerosols. The several studies that I've read is it reduces the aerosol contamination up to 90%. And now imagine you're going to reduce that aerosol, but because the dam is in place, you also don't have the concentration of viral particles or bacteria that are in that aerosol. So you're going to work with an HVE. And so you are going to, want an assistant in there versus just using a saliva ejector, and lots of great, HVE devices today versus just a traditional HVE adapter. So some people like the kind with the holes in the ends so that they don't suction up, get stuck to the dam. They have different tips now that flare so they can catch more of the aerosol. So great variety. HVE tips wasn't something I spent a lot of time researching previously, but now you have to be a savvy consumer and look at all the stuff that's available for us. And then at the end of the procedure, if you're using an Optradam, I do encourage that you actually cut the dam material that goes through the interproximal contacts versus trying to just pop it off. We don't want to leave any dam material accidentally down there. And so I just pull the rubber dam pretty far to the labial. I use scissors with a curved end, and I make sure that I can see the entire end of the scissor. And then we just snip the dam material and the whole thing pops off. One of the things about working with a rubber dam or an Optradam is people always go, well, my patients hate them. Patients aren't going to want me to use that. And I actually hear that about a lot of different isolation devices. Oh yeah, they're great, but patients don't like it. It's too much in their mouth. It's uncomfortable. I will tell you, like anything that we do in our practices, if we can help patients understand the value, if you can share with your patients why you're doing something, and that why is in their best interest. We're going to use this device because it's really important that we keep your teeth dry while we do this new filling, because the better we isolate your tooth, the longer your filling will last, and it's less often you'll have to be in here having me redo this dentistry. That we're going to control the bacteria so that there's a smaller chance that this tooth might have a problem and end up needing a root canal. And today, so far in 4 days back in practice, I can tell you anything that I say to my patients, we're doing this to optimize how we're protecting you and protecting every other patient in our practice and protecting our team. They're like, absolutely, let's just do it. And so my experience, no matter what we're talking about, and you could give me a whole range of things. We could be talking about fluoride varnish or chlorhexidine varnish at a hygiene visit, or placing an Optradam. My experience of when patients push back, it's because patients don't understand, they don't own why that thing is valuable to them, is in their best interest, or sometimes even in our best interest. It's amazing to me how much patients want to help us. They want to make what we do easier. And if they just think what we're recommending is like when we get supersized when we go through a drive-through, they're going to push back and say no. But if they actually have that piece of information about why this thing we're doing adds value, the inconvenience piece of it suddenly goes down as a barrier. Even the fee piece of it goes down as a barrier. So especially right now where we have more time with our patients, because I think we're all lightening our schedules a little bit, this is a great time to spend a little bit more time in conversation. That conversation might be behind a mask and a shield, but you can still have that conversation and help people understand what we're doing, and help engage them as a partner in the process of all the new things that we're adding. And as we said, this new novel approach to dental practice. I have been super impressed and thrilled by the partnership that my patients have shown this week and their willingness to do and participate in what we do need to do these days in practice. And so I hope that's just a little bit of an overview, at least at this point, of some of the things that I'm doing in my practice. I know there's lots of other things that that are out there and that you can explore and that we can do. The kind of the way I've approached this so far is the things that are quick and easy to do. Let's do those. Let's get those done first, right? Let's, as we sometimes say in business, let's get the low-hanging fruit handled. And then let's look at and evaluate the more complex things and make the decision about whether or not that has value to implement. And so, pre-screening, taking temperatures, having patients rinse with hydrogen peroxide, increasing the personal protective equipment that we're all wearing in our office up to the new standards, not wearing our scrubs home, and working under an Optradam. For us, those are all easy things. They're quick. They're just not a big change from what we've been doing. So those, just get them done. And then we'll look at the next layer of things we can add to our practice. So I hope that's helpful. I hope it gives people a little bit of insight into some options and things you can do. Gary, we'll take it back to you.
Great presentation. Thank you, Dr. Brady. Can I ask you to share with our viewers what the Pankey Institute is doing during this time to continue to deliver exceptional education?
Gary, thanks for asking. You're right. I do wear a lot of different hats, and people ask me this all the time. So I do practice, and teach all over the place. And one of the things I do is help run the education at the Pankey Institute. Obviously, we stopped our in-person classes second week of March, I think like most of the CE facilities did. But we wanted to continue to support our community and support people who wanted to learn at the Pankey Institute. So we immediately launched a webinar program that we've been doing. The webinars are completely free, open access. We were doing them 3 times a week when we first started. This week, with people going back to work, we've taken them down to once a week on Wednesday evenings. But all of the recorded sessions are available on YouTube. Just go to YouTube and type in the Pankey Institute, and you'll find all of those webinars, huge range of topics. They're all about an hour long. And we're also launching online education starting the first week of June. So we're taking a few of our classes that we used to do in person in Key Biscayne, and we're actually going to offer those online in a series of sessions. So they're 10 CE credits, and it's basically 5 2-hour sessions. They'll attend live, but we'll also record those. And hopefully in the not too distant future, we'll actually get to offer our on-campus courses again and invite people to come visit us back in Key Biscayne. But for the moment, we shall see.
Perfect. Thank you, Dr. Brady. Well, if you have any questions or concerns or ideas for future episodes, please email us at webinars@henryschein.com. And please subscribe to our YouTube page by clicking the button below. Until we see you again, stay safe and stay informed.